going to start too complex, but I want to try to give some guidelines and also a bit of a framework of how to manage some of these conditions in children, and then also to really open it up as we go for questions and interactions and case discussions. So I'd really like it if you do have something that you want to bring into the discussion, if you could just message on the chat to start with, and I'll try to address the questions, or if the chat's not working, just unmute and speak up and we'll have a discussion. So that's really good. So just to introduce a few things, I want to talk about really a little bit on diagnosis, a little bit more about the approach when you're working in the ER and you come across those children with severe respiratory distress. Some bits of advice really about what to do when things aren't working with our existing sort of first line of treatments. And then a few thoughts about oxygen. And then I want to talk a little bit about the sort of OPD asthma management. Now, the outpatient asthma management is something I could talk about for probably years and years, or at least a week. So I'm going to go on that very briefly. And then later on, we're going to have more of a discussion on that as well, because I think it's something that's undertreated. So, and I'm not going to talk a lot about TB or HIV today, because I want to save that one for maybe sort of 2 or 3 weeks time when we can have a proper discussion on that as well. So just to sort of start with, really, I want us to get into a little bit of the language of how we manage emergencies and how we approach a sick child. And it's very easy when you're confronted with someone who's sick to become distressed and to panic, and we all do it. You know, I fall into this myself sometimes as well. So really what I want us to think on is a framework. And you will have seen, if you've worked with me before, you'll know I love this thing of the ABC approach. So what's happening with the child's airway, what's happening with breathing, what's happening with circulation. And the approach being that when you fix the airway problem, then you can move to breathing, then you move to circulation, and then you move on from there. So that's kind of what I want us to get into thinking about throughout today. And really what I like when I see someone who has maybe seen a sick child in the ER, or they've been brought up from under 5 clinic, if I'm doing my round and I see someone's written airways, such and such, breathing, such and such, circulation, disability, dehydration, they've gone through that systematic framework and they've written, they've started with vital signs and they've commented on these other things. Immediately I think, okay, this person has a system and they know what they're doing. So it's very, very helpful to think through that. And I know it may seem very, very straightforward and simple, but that's how really a lot of these most sick children get well. So really, when you're confronted with a child respiratory problem, there's kind of 2 questions that you need to ask yourself. Firstly, are you dealing with a child who is at risk of respiratory compromise? And by that, I mean, is there a risk that their respiratory system is going to get to a place where they don't breathe very fast and their SpO2 starts dropping? That's the first question. And the second question is the child at a place where they're at risk of shock or dehydration? So the reason we worry about shock and dehydration in children with respiratory distress is if they're breathing very, very fast, then they will not be able to feed very well. So that's why it becomes probably our number one concern once we've realized that the respiratory compromise has been, has been looked at. So those are your 2 questions. And if you have any of those 2 present, immediately you're going to know this child will need to be admitted on bed. So it's not a child who is breathing very fast or in risk of either of those 2 things. You might think, okay, we need to admit this child. So before we go on to some videos, I just wanted to ask you guys some questions. So what would make you think a child is at risk of dehydration? Like what kind of things would they be telling you or the mother be telling you? Maybe ELWA Family Medicine can help yourselves. Is ELWA Family Medicine there? Okay. Okay. Just sort of opening it, just opening it out to the group, really. So things that would make you concerned that a child perhaps is at risk of getting dehydrated would be if the mother tells you the child is too sick to feed, or if the mother tells you, the child has not had any urine in the Pampers for a long time, and maybe the last 24 hours the child has not passed urine at all, or they say, the pipi is dark. You know, these kind of things will tell you that a child is getting into risk of dehydration or shock. So if you see those, you want to be thinking about, okay, we need to bring this child on bed. And the challenge, if you've ever worked in under 5 clinic, you'll know this is a challenge. You'll see maybe 100 plus children coming in every day. Out of those, maybe 90% will be fine. You can send them home with antibiotics or some other thing. But there will always be those who are very sick. And those ones who are very sick are the ones that we need to identify. So I want to try just a couple of videos. If this works, I'm just going to give you some signs of respiratory distress, just so you can see. And you may have seen these already in your work in the, particularly in the ER. Okay, so can anyone help me? I think if ELWA medicine, there's a Zoom that's ELWA family medicine. If you can unmute yourself so that I can ask you questions, that would be super helpful. What did you see in that video?
Well, I saw the
There was a retraction.
Retraction, very good. Anything else you can see?
Yeah, apart from retraction, also the child is using extra muscles, or what we call the accessory muscles of respiration.
Okay.
And if you look at also, there are some kind of flaring. There is also signs of flaring of the
Wonderful.
LNS. Yeah.
Very true. Yeah.
This child actually looks a bit very, because obvious that is very stressed. This child looks very anxious. You can see the whole eyes are wide open, besides what you mentioned already.
Exactly.
This is very respiratory.
Very good.
Exactly.
So all those signs, and you can actually hear a little sound as well. It may not have caught too well on the Zoom, but you can hear like a kind of a grunting sort of sound. And that tells you the child's respiratory distress has become so bad that there's almost like a sort of a blockage as the child's trying to breathe out. So you can see all of those things. The eyes are very wide and staring, which tells you the child is very distressed and very scared. And when you're hypoxic, it's very, very scary. If you've ever had a severe pneumonia, or if you've ever had even if you've been trapped underwater and you can't breathe, it's extremely scary. And that is how this child is feeling. So I wanted to give you another one, just to see what you can see there.
Wow.
Okay, there's kind of one obvious sign you can see there. If you've already seen this video before, try not to say. Yeah, go on.
I think there's some level, even though there's some chest indrawing, but at the same time there's paroxysmal type of chest movement.
Very good.
Yeah.
Yeah. So kind of paradoxical chest movement, which also you call it sternal retraction. Now that's a very severe sign.
Yeah. Yeah, both ways, the more like the middle aspect of this is as she breathes, or child breathing goes in, even supra contraction injury.
Very good.
And this is the highest, one of the of respiratory distress, one of the highest level, kind of way with the previous child. Quite severe. Yeah.
Very good. So I would say this child here is actually more sick. The reason for that is that this one is actually is on oxygen and still has all those signs. So, I mean, we don't know how much oxygen is going, but we can see the nasal cannula are there. And the fact that the child is still breathing so rapidly tells me that there's some really concerning signs there. So that tells me straight away that this child has a more severe respiratory.
So Dr. Mikey.
Yeah.
Mikey, the prevalence of this the sternal respiratory reset. So I was more with airway obstruction with foreign body or something like that to say on level of upper disease or something.
Very good.
What was actually this case?
Yeah, so this particular child had a very severe pneumonia, but you're right. Sometimes if you see very bad sternal retractions, that can mean that there's an airway obstruction as well. Or it may just be an airway obstruction. So that's a very good point. I think Dr. Garner is making there, that if you see sternal retraction, that can sometimes mean that there's an airway obstruction, whether that be a foreign body or a severe infection somewhere in the airway. Any of those things is a possibility. So definitely worth considering that. Good. Okay, I wanted to give you some signs in an older child. Let's see what. Okay, so there's one kind of extra sign there. Can anyone tell me what that is? There's one that we haven't really talked on so far.
Sorry. Where is it? Please, can we replay the video again?
Yeah, sure. Let's try that.
Like this.
Yeah, so if you look at the neck, do you know what that one's called? Sure. So it's basically, there's two words. It's either suprasternal retractions or tracheal tug. Okay. So you can just, it's just another form of retractions, really. Yep. Oh, so that's basically just another one. So I just wanted to talk a little bit about severe respiratory distress and give you a bit of a systematic approach. And you will probably know some of this already from these videos. So I'm not going to go into huge detail, but when you're doing your ABC assessment, when you get to B, first thing to write is usually what's the SpO2 and add that to how much oxygen the child is using. But then you also look at things like, is there increased work of breathing? Is there indrawing, flaring, head nodding? We've seen all of that in these pictures. Is a child lethargic? Now, lethargy is a really dangerous sign because that means that your child may just soon stop breathing. And if you've, some of the children who passed away, if you've seen them, what you will see is there's fast breathing. And then if they get very sick, then breathing gets slower and then they eventually stop. So if you see a child who's very lethargic, be concerned, and particularly children who are unable to feed. And then you're listening. We're going to talk about wheeze and what to do with that a bit later. Other things such as gasping, grunting. And we all know what apnea is. That's the absence of breathing. A child who has apnea, that's a really dangerous sign. And then feel. Feeling for equal chest movement. What would cause unequal chest movements? Can anyone give me any answer?
Right.
Condition that will
So
be.
yeah. So
Yeah,
so
like chest trauma, like chest trauma.
Good. Yeah.
Yeah.
Anything
Sometimes you
else?
have if you have a pneumothorax.
Good. Yeah. Good.
Pneumothorax in one part of the lungs, or one part of the chest.
Yeah.
Yeah. And sometimes if you have even in case of severe consolidation also.
Okay.
Yeah. Or pure effusion in one part of the lungs.
Wonderful. I think you've got all the big ones there. So pleural effusion, pneumothorax, those are your big ones, really. And sometimes you'll see it from the end of the bed, but sometimes you will need to be sort of holding your hands around. And I mean, it's something I can't really describe to you. I'll have to demonstrate it, but you put your thumbs in the center of the chest and you let the child or the patient breathe out. And as they are breathing out, you will find that basically your hands will expand differently. And that can tell you pretty quickly as to whether something else is going on. And we all know these respiratory rates in SpO2. Now,
so
go on.
And another one I want to add is like in line with trauma, open body aspiration.
Okay.
If they fall and it goes so the right, because the right, because when it goes struck at that low, you can also go chest movement because of their patients. Yeah, I've seen patients who have But in those instances, obvious obstruction, like in addition to others, lower large chest pathology, you can have unequal action or movement.
That's very true. What you get is basically obstruction of the right main bronchus. So that leads to, a lot of difficulties, really. So yeah, very, very true. Very good addition. And then we're going to talk a lot more in detail about treatment as well, but just want to give you a few immediate actions. So if you're the sort of person on call for ER, it's the middle of the night and you get called to one of these children, your immediate steps would be looking at oxygen flow. Now, we're going to have a whole thing a bit later on oxygen, but really there's a couple of things. Looking at a child's age and size really should dictate your flow rates. Now, we don't at ELWA have the ability to really modify the concentration of the oxygen. It's pretty much sort of 90 to 95% concentrated oxygen just coming out. But what you can do is modify the flow rate from 0 to 5 to 10 liters, etc. Now, oxygen is a drug, so it's important to treat it that way and try to prescribe it if possible and try to specify how much oxygen. So that's actually very helpful. So if you have a child whose SpO2 is say 99 and they're only using 1 liter of oxygen, that tells you that that child is doing better than say another child 4 liters of oxygen and say their SpO2 is only 85. So that's why it's very helpful in your notes to document how much oxygen is the child using, how many liters, and to try to tell the nurses or the PAs, whoever, they say, okay, overnight, I want you to put this child on 2 liters or 3 liters. And then you can see your progress through the night. I'm seeing a little question. I'm going to just, okay. Well, okay. Thank you for your service, Dr. Gorno. We'll catch up with you later, and these will be recorded, so we'll get you a copy of these as well. So that's okay. I think ENT is quite busy right now, so that's okay. So other things to consider, sitting the child up at 45 degrees. And then you're looking at what's our diagnosis. Are we going to be needing antibiotics, bronchodilators, and then fluid management? That's really important. The reason fluid management is so important is because a child who's breathing very fast is not able to feed very well. So they're going to start getting dehydrated. But also, you don't want to overhydrate a child with respiratory distress, because if you do that, you're going to put fluid potentially on the lungs and make it worse. So monitoring your respiratory rate and your SpO2 are very, very important throughout fluid management. That's really important. So diagnosis in children. Now, this is where children and adults are very different. So if you're diagnosing a respiratory condition in an adult, you're usually thinking about your clinical signs and your symptoms and maybe 1 or 2 investigations, and that will get you there. In children, usually you're looking, the number one thing you're thinking about is actually a child's age. So you're looking at the history as well and what you're finding on exam, and you may want to do tests later on. But the thing which is going to tell you a lot more is actually what age is the child, because that has an impact on their airways. So obviously a much younger child, less than 1 year, is going to have different problems with their airways, because the airways and the bronchioles are much, much narrower. So this is a really, really simplified thing. This is just a summary of what we're going to go through. The under ones, generally you would expect them to have usually either bronchiolitis or pneumonia. As they get older, we start calling bronchiolitis viral wheeze, because that's what it usually is. And as they get older, and if they keep having recurrent attacks, which we're going to talk about in a little while, you might be thinking about asthma. But take home message, pneumonia is probably the one thing that's going to kill people the most. And it's possible at any age. You'll have neonates with pneumonia from meconium aspiration. You will have 16-year-olds with pneumonia. You will have malnutrition children who get pneumonia due to aspirational issues. You'll have maybe 2 or 3-year-olds who perhaps have viral wheeze and then develop pneumonia afterwards. So it needs to be considered anywhere. So I'm going to take this away. I'm going to ask some more questions. What would make you think a child has pneumonia, not anything else? What would make you think?
I think we look at the respiratory rate.
Okay.
And the history of fever, from the history of fever.
Very good.
These are the signs of respiratory, although you will see in our bronchiolitis, but the history of fever will distinguish it from bronchiolitis.
Okay, certainly, yeah, you usually have a higher persistent fever in pneumonia, yeah. What about your clinical findings when you examine someone with pneumonia? What are you going to find?
Yep, someone with severe pneumonia, we will have chest indrawing.
How about when
you have increased respiratory rates, sometimes low SpO2 in severe pneumonia, and we have crackles.
Okay, crackles is one thing, yeah. Anything else that you'll see? Possibly, like when you listen with your stethoscope, crackles is one thing. There's something else you might hear.
Sometimes maybe grunting, or some of our wheezes will be for probably bronchiolitis or.
Okay, good. So wheezing would be more likely to make you think of bronchiolitis or asthma or viral wheeze. But the other thing you'll hear is something called bronchial breathing.
Breathing. Okay, yes.
Yeah, good. So if you want to know what bronchial breathing sounds like, you may know this already, but if you get your stethoscope and you put it in your ears, and then you take the end of it and you put it on your trachea, so on in your neck, and you listen to the sound of your own breathing, that's what bronchial breathing sounds like. And that's another sign of pneumonia, really. So just to go through, these are usually the more unwell children with respiratory problems, as you said there, all the signs of respiratory distress. But be aware, some of them, they may just have a pyrexia of unknown origin or reduced feeding. And this is sometimes because chest signs can be a little bit hard to pick up, particularly if you're working somewhere like under 5 clinic and it's very noisy and crowded, and lots of people are sort of humbugging you for things all around. It can sometimes be quite hard to diagnose. So it's very good to think about the possible causes, really, of pneumonia as a possible cause when you have a pyrexia of unknown origin. Other things worth considering as well, I mean, particularly if you've got a child who's immunocompromised. Now, the obvious one is spot active, but then other causes as well that are there. So a malnourished child may not actually have a lot of obvious chest signs at the start, but may just have a pneumonia. And also children with pre-existing lung disease. So I'm thinking particularly children with asthma, but also children who may have had TB already or some other thing has got in there. Cystic fibrosis may be a possibility as well. So it's worth just bearing all of those things in mind. And just to say again, all ages, it's an infection of the alveoli. Predominantly, I mean, the airways are involved as well. It can be any cause. I mean, it says viruses or bacteria there, but really fungal infections are a problem. What's the most commonly seen fungal pneumonia in Liberia? What do you think? Have a guess. What if I told you the child was immunocompromised and then you noticed that the child was getting wasted and their SpO2 was dropping, but the chest did not really sound too bad, and the spot is reactive? What kind of pneumonia do these children get?
That's PCP.
Yep, PCP or PJP, pneumocystis, as I did. In PCP, pneumocystis carinii pneumonia, or pneumocystis jaravoci pneumonia, it's the same thing. Yep, very good. So that's another possibility to consider as well, and that's why they find themselves on cotrimoxazole. So those are things you've already said, really, in the history. Difficulty breathing. Sometimes children do get abdominal pain as well if they have pneumonia. When I was working in the ER here in Wales, all the way back in 2013, we had one child almost taken all to the OR with abdominal pain. Someone thought it was appendicitis, and they were about to go to the OR, and then one very senior professor examined them and said, "This is not appendicitis, this child has right lobar pneumonia." And that was the correct diagnosis, but it was resulting in referred pain all the way into the abdomen. So it's worth considering. And then our look, listen, and feel, again, we know all those signs there. Can anyone tell me where's the pneumonia here? Where can you see it? Or what can you see? Just have a guess. I mean, firstly, which X-ray is normal, which X-ray is not normal? You can answer in the chat if you like. Any ideas? Okay, so it's quite hard to do the Q&As on Zoom, but basically, if you can see the red circle, this patient actually has this is an older child. I think this patient's more like sort of 15, 16, but there's a right mid-zone pneumonia, and you can see the consolidation there on the chest X-ray. Now, I want to say a little word about chest X-rays. Now, we don't need to do as many as we think. So the reason for doing a chest X-ray really is basically to look for something that we're going to treat differently. So if you have a child with all the clinical signs of pneumonia, if they've got those crackles, those bronchial breathing, they've got obvious signs, I'd be treating them as pneumonia anyway. if I was not seeing an improvement, or if I was looking and seeing, worried about perhaps a pleural effusion or something like that, or TB or pneumothorax or something, then I'll be thinking, okay, then we need to do an X-ray. So it's just an indication of who needs an X-ray, who doesn't. And the main reason for that in children is to do with the radiation. So really every time we do an X-ray, or I mean, much worse would be a CT scan on a child, you actually increase the risk of actually reducing their IQ longer term. So that's why we use X-rays reasonably sparingly. And if you look really closely at the X-ray there, you can actually see there's some blunting of the costophrenic angle on the right side. So if you look at the first X-ray, that's the one should be on the left, looks nice and normal. The second one, if you look right at the costophrenic angle, you'll see a little bit of fluid just starting to fill up in there, and there's a bit of a meniscus. So not only does this child have pneumonia, but there's also a little bit of a pleural effusion just starting there, which is probably a parapneumonic effusion. And this is your super simple guide to basically what to do and who needs to come on bed. You'll have seen this many times. It's straight out of the WHO pocketbook. So I'm going to try and bring WHO pocketbooks with me in about 3 weeks when I come. So I'm going to bring them all out for you guys. They're super helpful in terms of how to go about things day to day. And really the ones you're looking out for are your severe pneumonias. So as we were saying at the start, any child with a danger sign, which would sort of suggest that they've got worsening respiratory distress to the point of needing oxygen, or any child who has any signs that they might be getting either dehydrated or slipping out of consciousness, they need to come on bed. Now that is probably about 1 in 10 of your children who come with respiratory conditions. And really my advice to you is, if in doubt, bring them on bed. It's always safer. You know, we do have a special program at ELWA. The costs are not heavy for children. If they can't manage, we'll find a way for them. So it's always really important, if you are seeing these children, try to stress to the mothers the danger signs that are there. So just want to give you a bit of a framework for the emergency sort of management. And some of this you'll see up on the walls. I hope it's still there in the ER. Remember, your 45 degrees is really helpful in terms of how to nurse these children. That helps any sort of secretions get out of the way. And then looking at your antibiotics. Now, ampicillin, gentamicin are still our first line. We're going to talk in the next little while about what to do if they're not working. And really, sorry, there's a slight mistake on here. Actually, when I've written pneumonia and amoxicillin, 40 milligrams should be 40 milligrams per kg BID, or TID is equally fine as well. Now, try and control the temperature if you can. It's helpful. The reason we worry about a temperature in a smaller child, especially, is we don't want them to start having a febrile convulsion. If they do, then there's a risk of aspiration. So that's why we generally want to control that. And remember, never forget your supportive care. So if you have a child who's too breathless or breathing fast, putting them nil by mouth is very appropriate. What I want to say is, well, once you've done that, it's not just a fire and forget with your amp and gent. What you need to be doing, usually by this point, they should have gone to the ward. So you're reviewing the situation. If you're not seeing any improvement in 48 hours, then you need to review the antibiotic choice. Particularly a macrolide is a good idea. A severely sick child, you want to use ceftriaxone. Now, remember the risk of aspiration. So this is actually something that you'll sometimes run into, especially in malnutrition wards, is if there's been a problem with the NG tube or something else, then you would want to be using metronidazole IV. So that's your sort of your second line backup. But we've seen really good results and outcomes with azithromycin. Next thing after that, if you're not seeing improvement on 2 lots of antibiotics, your immediate next thought should be TB. That should be in your mind straight away. So that's the point at which I'd be wanting to hurry up and do an X-ray and see if there's anything to see. Now, beware with TB. Ideally, you would want to do a gene expert process, but it's important to realize that a lot of a lot of children will not be able to aspirate sufficient sputum for you to get a good sample. and often the gene expert machine isn't working. So it's perfectly okay to get a chest x-ray. That's the easiest way of doing it. And then remember the maintenance fluids. So I'm aware there's two ways of doing it. You've got your 421, and then you've also got the 100 mils per kg, 50 mils, 25 mils. As long as you have a system, that's good. What I would avoid, and we'll talk about maintenance fluid later, what I would avoid with maintenance fluids is prescribing just one volume over 24 hours, because if you do that, what will happen is you will find the whole thing will go very fast, and then there will just be a long pause where nothing's happening. So it has to be really every, that's why I like the sort of 3-hourly feeds and fluids to be going on. So we'll talk about maintenance fluids later. I want to talk about wheeze. What if a child is wheezy, what does that tell you if you're hearing wheeze with your stethoscope? Any ideas? Okay, so basically,
hello.
Yep, carry on.
It'll be narrowing of the airway. So like,
wonderful. Yep, narrowing of the airway, perfect. Can you tell me some conditions that would give you narrowing of your airways in your lungs?
Asthma could do that.
Asthma, yep. Any others? Okay, so we're just going to go through a couple of those. So basically, under ones, we're looking at usually something called bronchiolitis. Now, commonest cause is something called respiratory syncytial virus. And most children who get this, it usually comes in waves, and it's usually self-limiting. But in about 10%, you'll end up with children who have more severe illness. So these are the ones I want us to focus on. Now, just to be aware, in a child who's less than 1 year old, there's actually no benefit to salbutamol inhaler because the airways are actually too small to benefit from a bronchodilator. And there's no benefit to steroids either. So these children, it's about using oxygen. You might want to look at the supportive side, so IV fluids. And if they're very unwell, you'd probably want to use antibiotics to cover a sort of a superadded pneumonia. So you would look at that as your treatment plan. So in many ways, a bronchiolitis child you may feel like you're not doing a lot of active stuff because it's very tempting to start giving all these other things, but actually there's not a lot of evidence for that. And the concern, certainly in under ones with using hydrocortisone, is it actually suppresses the immune system anyway. So I wouldn't use a hydrocortisone if a child's less than 1. Now, as they get older, you get we don't really call it bronchiolitis anymore. We call it more of a sort of viral induced wheeze. And the reason we call it that is basically the treatment plan is actually different. So it helps us distinguish which way we're going. So a child over 1, we say viral induced wheeze. There may be other types of wheezy cause as well as they get older. But things that you're going to hear wheeze, so that's that whistling sound when they breathe out. If they've had recurrent attacks, you may look at the chest and be hyperinflated. There's a few children who are around who definitely have asthma that I've seen come in and out of ELWA, and they've got these hyperinflated chests. So for these ones, I just want to talk through a little bit of a treatment plan. And this is your first lines of treatment. We're going to talk about what to do if this isn't working later on. But your first line is 10 puffs using a spacer. Now I'm going to show you pictures of spacers, and there should be a few on the ward, but they're very underused. So a salbutamol inhaler using a spacer doing 10 puffs is equally good as a salbutamol nebulizer. There's evidence in pretty much all the literature to say it's of equal value. And the reason I want to use the inhaler with the spacer rather than a nebulizer is because a lot of the time we don't actually have the correct nebulizer fluid. So you'll see sometimes people are putting steroids in the nebulizer or just straight ipratropium, and those things aren't actually going to help as much. So the reason we use a spacer, if you try to give a child who's, say, 18 months, you try to just put an inhaler in their mouth and make it work, it's not going to happen. So that's why we use a spacer. I'm going to skip right ahead and just show you a picture. This is a spacer here, and you can see particularly this guy here on your screen's left there. You can see he's got a little mask on him. I'm going to bring more of these as well in October. And he's got the inhaler. And the way you do is you press the inhaler, you count to 30, you press again, you count to 30, and you keep doing that, counting to 30 in between each one. You do it 10 times. And that's how you end up with a child who is able to, that's how you end up with the child being able to breathe in enough of the salbutamol inhaler. So when you're doing this, you need to really stress to the nurses, they need to take their own time, because sometimes you'll see them do it. They'll put the spacer on, they'll do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, they'll rush back and carry on their writing. So you have to really take your time to explain that they need to be doing it slowly. Something, again, we can have a practice at. But that's a very important piece of equipment for a child who is wheezy. That's your first line. Second thing you want to do is you want to be using the steroid. So you can actually be using a lot more hydrocort than we think in a child who's very wheezy. You can go all the way up to 4 milligrams per kg, even QID. And prednisolone you would want to use. Again, it's a high dose, 2 milligrams per kg. That would just be QD. And so that's your first kind of line. Now, I want to just talk through asthma, and then we're going to talk about some of the slightly more complex treatment protocol I want to share with you guys. So asthma, generally, if you want to diagnose it, you have to say usually the child needs to be older than 2 years. Some literature even says 5 years. The reason for that is that most children will usually have a lot of cough, cold attacks or wheezy attacks, and then usually they grow out of it. So we don't want to label a child as having a lifelong condition very, very early on. We want to sort of take our time with that. But generally, there's a lot of questions in the history. So what you will find is usually there's recurrent attacks. So asthma, it's not just a one-time thing. There's associated wheeze, shortness of breath. They're using their inhalers more. There may be set triggers. So they may say, oh, whenever I play football, whenever I run, this is what happens to me. There's dust sometimes, and also infections as well. And again, very similar sounds to what you're going to hear on a child with viral wheeze. Now, I want to show you a different thing. I'm just going to put in a new screen share now. I want to show you. Can everybody see a sort of a Word document with acute exacerbation of asthma at the top? Can people see that? Hopefully. So there's this is a kind of a different kind of protocol that I want us to start looking at for asthma exacerbations. So generally, what you want to do is try to classify these children into how severe they are. And this is for slightly older children. So a more kind of mild and moderate, this is a child who's maybe walking, speaking whole sentences. You would want to just be doing your puffs of the inhaler. Now, as they get older, you move from 10 puffs to either 6 puffs or 12 puffs. Doesn't matter too much. We won't sweat too much on the amount of inhaler. As they become more severe, then you want to also be adding in this thing, ipratropium. Now, we may not have this. So if we don't have it, we don't need to worry too much about it. But that's the important thing to do first, is to look at a little bit of categorization. I want you to look at the categorization there. So any child who's drowsy, exhausted, poor effort, SATs are less than 90%, and they're just not breathing as they should, that would tell me there's a life-threatening situation. Now, in that situation, and these are rare, what you want to do is you would want to use a nebulizer. The reason for that is the child may not even be able to inhale enough using the spacer and the inhaler to actually get enough in. So in that situation, you want to use a nebulizer. And I do know that we have some of these combination nebs floating around ELWA with salbutamol and ipratropium together. So that's what I would do in a life-threatening situation. Now, a child who's a little bit less bad, they are breathing fast, they can't complete a sentence, their SATs are maybe 92, 93, I would still use an inhaler because they can get more of the air to come in. Then next step, you might want to do the same thing again. So what I want you to notice there is the repeating of the dose. So 20 minutes for the first hour. Now, it's really important to, these are children that you have to keep coming back to. So it's easy to think, oh, I've done my 10 puffs, everything's fine. Now the child is starting to improve, we can carry on. But you need to come back to that every 20 minutes for the first hour, just to keep doing the same thing. And then you'll see a lot of improvement. Next one, you want to be doing your steroids, which we talked about. I want to note the next point. If you're not responding to steroids, then your next step ideally would be magnesium sulfate. Okay, so magnesium sulfate, you can use it for all sorts of things. I mean, you'll know a lot about it in obstetrics, you use it in intensive care settings, but you can definitely use it in children who have very bad asthma and in adults as well, for instance. So I want you to note the dose there, 10 millimoles of magnesium sulfate in 100 mils of normal saline over 20 minutes. So it's a slow bolus. Now, where sometimes people get confused is they just stick it in the normal saline and let it run through very slow. Now, that's not going to work quickly enough. So you want to try and get the nurse to sit with the patient and do it as a slow bolus. And then the thing you do next, you reassess, you see where you are. If your breathing difficulty is persisting, then you're going to be bringing this child on bed. I would say probably anyone who's needing magnesium is going to be coming on bed. And you want to prescribe your bronchodilators, your salbutamol, regularly. So after your first sort of hits, 3 times in an hour, if they're very severe, you might then say, okay, I want you to come every 1 hour, every 2 hours and do 10 puffs. And you then say to the nurse, you give them criteria for medical review. So what I normally say to the nurse is, I'll try to say to them, call me if you see the SpO2 is dropping or the pulse rate is increasing. So you give them a number. So say if the SpO2 is below 93, call me. If the pulse rate is going above 160, call me. That's why the ping machines, I know they're all spoiled, so we'll get some more, but that's why they're very, very helpful, is they tell you what's going on very quickly. Now, later on, hopefully your child is improving, you want to move to your discharge plan. So you want to send the child home, usually with an inhaler and a spacer and some good education. So this is where you guys, again, there's no point me trying to do education with the patients because they will not hear me clear. So really this is important as a thing for you guys to do, is a salbutamol, instruct them on how to use a spacer. You can make them out of bottles. It works exactly the same way. We have a few spacers as well, so you can just give them a spacer to go. And prednisolone normally for 3 days. The evidence is a bit conflicting. Sometimes they'll say 5 days, and tell them that they need to come back and see you if there's any sign of distress. And I would also give them follow-up in under 5 clinic in 1 or 2 weeks. So that's just a really helpful protocol for an asthma exacerbation. I'm going to try and get these sort of maybe emailed around everybody. So just to give you that framework. Now, I'm really sorry, time is running a little bit thin. So I'm just going to do 1 or 2 more things, and then I'm going to unfortunately I've got to jump to another Zoom meeting, unfortunately. But we will definitely go through questions on the next time I'm there. So I'm going to just switch back to the PowerPoint share there. So just some questions to ask. You know all these things already if you're in an outpatient setting. Family history, very strong with asthma. Other atopy causes, so rashes, hay fever. Is there a diurnal rhythm? Are there frequent admissions to hospital? Triggers. And then when you're in the OPD, again, I'm going to try and design a good protocol for this, but your first line would be a sort of salbutamol on a PRN basis. Then you want to be looking at a low dose steroid BID. So beclomethasone, otherwise normally called Clenil, is the one that's the make that we have here in Wales. I think it's the same there. You want to use it on a regular basis. And then if there's an ongoing attack still on the steroid and using your salbutamol, then you want to use something called montelukast. Now that's a tablet in the evening. So we're going to cover this in a bit more depth, the outpatient side, I think next time. But I just wanted to give you a bit of an introduction. And again, very sorry that I have to unfortunately pull myself off to another Zoom meeting. But what I want you to do, I'm actually coming back on again, I think next week. So if you can make a note of your questions, I'm going to make sure that this gets sent to all the right places. If you have questions, we'll open the next session with going through those questions. So just to say, very, very common. Do your ABC assessments and think systematically, remain calm, and you will be absolutely fine. And a lot of these children will be very, very sick when they come in. The important thing that you're doing as a clinician is being organized, having your ABC approach, and really trying to direct the nurses and the PAs in how they're giving their care. Some of them will know some of this if they've been through ETAP+. They will not know as much as you do. They will not know about magnesium. They will not know about any of the outpatient stuff. And they will not necessarily be able to distinguish a wheeze and a crackle and make a solid diagnosis. So that's why really you guys are super important in managing these sick children. So I'm going to need to leave it there, unfortunately. So sorry for that, but thank you so much for listening. And I think we'll do questions on the next one, unless anyone has any real emergency question right now. I'll just come back to my face. There we go. Okay, that's fine. So I probably have to go, unfortunately, but thank you very, very much. And I think I'm next with you, hopefully sometime next week. So we'll open with questions from this one then, and we'll go into some more detailed topics then as well. So thank you very much for listening. Really appreciate you guys. Thank you for serving so wholeheartedly at ELWA, and maybe some of you are in Harper as well. Hugely appreciate that. So thank you very much. God bless you guys. And see you very soon.
Thank you.
Thank you.